Thanks for the introduction, Toby, and thanks for inviting me to talk. So I sort of feel like, I mean, nobody's really an expert in managing CAR T, because it's quite new, isn't it? So I think, and it's like anything in medicine. I think if you gain experience and it's fine, so I wouldn't be too stressed about it. So I've just got one case, and I think it illustrates, the various problems that can happen during CAR T. So I mean, mostly in Cambridge we do lymphoma CAR T, because I guess it's quite unusual to do ALL. So I think we've only done 4 cases of ALL since CAR T program started, and about 40 or 50 lymphomas. And this was a fairly typical case. So it was somebody who had originally low-grade marginal zone lymphoma, who transformed to CD5 positive diffuse large B-cell lymphoma, had R-CHOP, then progressive disease with a double expressive immunophenotype shown on the PET on the left. And then she had salvage chemotherapy of RGDP with a poor response, as illustrated. And so then she had a biopsy which confirmed persistence of high-grade lymphoma. She was approved for CAR T therapy in the CAR T cell panel. So I mean, we mostly use axi-cell. I think that's almost all. I think we've only done a couple of Tocel. So she was approved for axi-cell, and I think that's just because the feeling is that they do a bit better, although the toxicity is greater. And so when she was leukapheresed, and she had bridging with R-bend Apollo, which is what's almost always used, apart from if there's localized disease when we use radiotherapy, which I guess Tobias was talking about. I caught the end of his talk, and that is very typical for what we do as well. And then she had a PET-CT post for the first cycle, which showed active disease on both sides of the diaphragm, as illustrated. And so she came in for CAR T. So she came into CAR T with active disease, which is a bit different to, I guess, other transplants. And so sometimes they are a bit unwell, and may sometimes, be extreme. They sort of have fungating lymphomas and stuff. So it's all slightly odd. And this is a sort of schedule for, just to remind you of what happens. So they start with lymphodepleting chemotherapy, which could in theory be ambulatory, which goes for 3 days, and we get this 2-day gap. Then we get CAR T infusion, and then there's this inpatient period of monitoring for toxicity. And then if all is uncomplicated, then we get just discharged on day 10, and then get monitored. And I think it's unusual, to be honest, for them to be discharged on day 10, so they often stay longer than that. So the chemotherapy, which is used for lymphodepletion, which was put down there, is fairly light. So I don't think they don't tend to get a lot of toxicity from that, to be honest. So I think in terms of the toxicity, so obviously it's related to conditioning chemotherapy. The side effects specific to cyclophosphamide and fludarabine, which everybody will be familiar with, and then infection, obviously, because they become neutropenic. And then there's those related to CAR T cell therapy. And the two main ones, the two most common ones by far, are CRS, cytokine release syndrome, and ICANS. And I think the other ones, in terms of inpatient management, I've never seen. So I think secondary HLH is listed, and I think they do sometimes head towards it, but I've never seen anybody needing specific HLH directed therapy, so I think that's quite rare. There's a handy app, ASTCT, which sort of has all the calculators and algorithms, which I would download and use. And once they've had the cells, then they get scoring 3 times a day for CRS in terms of grading, and ICANS in terms of grading. That's what we do locally. And this is the sort of typical time frame, and it is often exactly like this. So they get the cells, and then they start getting CRS, and then a few days later they get the sort of neurological toxicities, and then depending on how severe they are, they get treated, and then they go home. And it's almost always like this. So I think this can sometimes, the time period to the development of these shifts a bit dependent upon the products, so it can be a bit later or a bit earlier, and axi-cell tends to be quite early. So before we start, before they get the cells back, then they always get a checklist completed, which at the moment in Cambridge has to be completed by a consultant, which is always slightly tedious. And this is mostly based off the trial stuff, and to make sure we've got no infections. And I think if somebody had a bad infection after lymphodepleting chemotherapy when you could, in theory, pull out, because that would increase the risk of sort of toxicity. So that's always completed before we start. So in terms of this lady, so this illustrates, very typical, almost always what happened. So she got the cells on day 0, and then she spiked a fever, and the fevers can be, very high, 39, 40 often. So she spiked 39.2. And then she sort of was managed just on the ward for the next couple of days, and then she developed CRS grade 2, and I'll just talk through the different bits of those. So this is our protocol for managing CRS. So CRS basically is graded grade 1 to grade 1, 2, 3, 4, and you have to have a fever over 38. So that's your sort of starting criteria to get into CRS, unless you've had tocilizumab. So once you've had tocilizumab, you don't necessarily have to have a fever anymore. And for grade 1, which is very common, then obviously you don't know if they've got an infection or not as well. So they always get cultures and sort of antibiotics, which are managed. Do you want me to answer these? I'll answer these questions at the end if that's okay. But if you just pop them into the chat. So once they've got grade 1, then they get infection screen, which is a standard septic screen, IV antibiotics, which they start. They can get ibuprofen, and that's sometimes quite helpful for managing the high fevers, which I know is a bit weird for hematology, but we do that unless they're very thrombocytopenic. And then if they continue to spike beyond 3 days, then we tend to give them tocilizumab a single dose, mainly because it's pretty uncomfortable to have high fevers, and sometimes patients get very symptomatic with that. And then for grade 2, which is when you start to think about treatments otherwise, then that's really hypotension. And I think when you're sort of starting off and you're doing the first couple, I can remember, like, I was on call with the first one in Cambridge, and it was all a bit like, when do we give tocilizumab, and what's hypotension, and how do you define that, and if you give a bolus of fluid and it comes up, is that okay, and all this sort of stuff. And I think it's usually obvious, so that's the first thing to say. So they'll drop their blood pressure, they'll get a fluid bolus, and then they'll drop their blood pressure again. And I think if you give more than 2 boluses of 500 mils, then that is grade 2 in my book. And I think if somebody is very hypotensive, you can just give tocilizumab. So you don't need to wait for arbitrary thresholds to be crossed. The arbitrary threshold that we normally use is 90 millimeters of mercury, but I mean, that is obviously arbitrary. And I think as soon as they're grade 2, then we tend to speak to ICU. And that's, we have an excellent ICU in Cambridge, and they're very happy to come and assess patients and take them even sometimes before they need to go to ICU. And I think that's helpful, I guess, just so they know about a patient and they've sort of assessed them and they know the baseline. And then, so that's grade 2, and grade 2 can normally be managed on the ward with tocilizumab and fluid. And then if they need inotropes, then that's grade 3. And inotropes are inotropes, so that's needing blood pressure support, metronidazole, noradrenaline. It's obviously managed in ICU, and so that automatically moves you onto needing steroids. So that is the sort of, then there's grade 4, which is essentially being super sick, so multiple vasopressors or intubation. There is also a sort of requirement for oxygen, which moves you between grade 2 and grade 3, and I think they can sometimes get a bit of capillary leak. So what you'll often see is if you give quite a lot of fluid, they'll end up getting a bit of polyedema. So I think it's important not to give them too much fluid, is what I would say. Wouldn't be too aggressive with that. So she followed a fairly typical path in that she was, by day 4, she had refractory hypotension despite 2 days of tocilizumab and IV fluid. She had a rising lactate, she looked quite unwell on the ward. She was neutropenic by that point, as you would expect from a chemotherapy. And so she was transferred to ICU, and she was started on noradrenaline, which automatically moved to grade 3 CRS, and so therefore she started dexamethasone, 10 milligrams QDS. And she also, over that next 24-hour period, had 2 further doses of tocilizumab. So there's only 4 doses of tocilizumab funded, so you don't, what you don't do, I guess, is give 1 dose and then give the second dose automatically 6 to 8 hours later. You sort of give it as you need it for hypotension normally, or that's the way we do it on the wards in Cambridge. And then you're never quite sure if they've got a sort of an untreated infection like you're missing, and so they often end up having their antibiotics escalated. It's all empirical. So she never had any positive cultures. There wasn't any really good clear evidence of infection. And as soon as she started with steroids, so she was now on ICU, she started with steroids, her blood pressure came up, within 12 hours probably, and she was off inotropes. And then I can remember it was a weekend and I went to see her, and the ICU consultant said she's just a little bit muddled. She's fine, he said, but she's just a little bit not quite as coherent as she was yesterday. And the way it's sort of assessed is they get this ICE score, which is listed there, and it's out of 10. And because they get asked it 3 times a day in Cambridge and at least twice a day, I think in almost every centre, then they get pretty good at it pretty quickly. And so it's fairly obvious if they are sort of neurologically affected. And so she, I think, lost a point for orientation, I think, somewhere. And so she was just 9 out of 10, which automatically moved to grade 1 ICANS. And so this is the grading for ICANS. And I think, so basically, if you're grade 1, so that's the ICE score, which is out of 10. So as soon as you lose a point, then that moves you to grade 1. And often they'll sort of continue to accumulate or lose points on the ICE score, which will move them across up the various grades to when they need treatment. I think the consciousness level is a bit less, tends to be a bit less affected, although they can be when they're very severe, sort of, not comatose exactly, but very difficult to rouse. And the other thing which is included here is seizures. And occasionally you can have patients, we haven't had one of these specifically, but I've heard about these patients who are fine on the ward and then just have a seizure, and automatically that's either grade 3 or grade 4, and so automatically needs steroids, and there we go to intensive care. And then the other thing is this raised ICP cerebral edema stuff, and I guess that's part of the benefit of doing a lumbar puncture. You then know the sort of the opening pressure if you do that. And so that's the ICANS grading. The treatment is here. And I think the most important thing to say, which is obvious and I'm sure will be emphasised across all the talks, is that tocilizumab does not treat ICANS in itself. So if you've got CRS alongside it, you give tocilizumab, but you don't give tocilizumab just for treatment of ICANS. And in fact, it can probably worsen ICANS a little bit. So the treatment for ICANS is steroids alone, if it's just ICANS alone. And we treat at grade 2. So that's, a fairly modest threshold for treatment sometimes, but I would just follow a protocol. That's what I always do. And there's a series of investigations that they go through. So if they're sort of grade 1, so which is what she was at the start, then they get a neurology referral. And I think the neurology referral, I would say, is often, I think it's helpful to exclude other causes, but often the neurologists come and say, this is ICANS, you see more ICANS than we do. And I think there's a variable amount of interest, I guess. I think, initially when it starts, and when you start CAR-T, everybody's interested, including neurologists, intensive care, and so on and so forth. But I think that becomes sort of there's less interest as these patients go along. And it's very stereotypical, and so it is usually obvious, to be honest, if it's ICANS. So that's grade 1. So for grade 1, they start Keppra as seizure prophylaxis and neuroobs, and then they just get monitored. And then for grade 2, then we initiate all the investigations, which is sort of cranial imaging and a lumbar puncture. And I think an EEG can be helpful, and neurology are helpful at sort of helping get EEGs, I think, and sort of can advise about, whether there could be any seizure activity. And then grade 3 and grade 4, they obviously get steroids. I think once you're in to grade 4, then I think there's a question about whether you escalate to pulse methylpred. And I don't think we've ever actually done that, because the dose of dexamethasone is not a million miles away from the dose of pulse methylpred you give, actually. And I think it is quite toxic, that. But I think we would consider that if it was grade 4 and not improving. And then the other thing it's helpful to think about, I guess, is whether we should have any other treatments in the algorithm, which we don't have formalised at the moment. But we've always spoken about whether we should use anakinra in that situation if it ever reached that point, although it never has actually in Cambridge so far. So she started Keppra. Her CRS had completely resolved, and she continued on with the steroids, and sort of followed a protocol of getting cranial imaging and LP if it worsened. And then by day 6, so she was about maybe 36 hours into the steroids now, then her ICE score was 5, and she was obviously dysphasic. She wasn't able to write the sentence that they always write. And so she was grade 2. And she had a CT, which was completely normal. And the lumbar puncture she also had. And I think you can sometimes get a little bit, like the lumbar punctures can be a bit confusing sometimes. So she had a high CSF protein, which is very common. And I have seen patients have a sort of lymphocytosis as well. And of course, that then leads to this anxiety from everybody about whether there's a sort of CNS infection, and often they end up getting treatment dose acyclovir and sort of CNS dose meropenem alongside that, although you can see that with ICANS. So her lumbar puncture was acellular and sort of held off, resisted the urge to start CNS infection treatments, and all the cultures and subsequent PCRs came back as negative. That just summarizes what I've just said. And she also had a neurology review, and I think the neurologist, she had a consultant neurology review actually. She was on intensive care, and one of the neurologists came to see her, who was sort of a LinkedIn neurologist, and she was helpful and sort of said, it's consistent with ICANS, did a full neurological examination, suggested an MRI and EEG, which happened. The MRI was also normal, and then the EEG was essentially non-specific and shows generalized encephalopathy, but no sort of specific seizure activity, which was reassuring. And so there was a little bit of anxiety about whether she should, because she was getting worse on steroids, whether she should escalate. We just sort of said, well, hold our nerve, and she then gradually improved. And then I think as soon as they start, she improved fairly rapidly, actually, over 3 days. And you start tapering the steroids. And I think the steroids, it's a big dose. It's 40 milligrams of dex. I mean, that's a big dose, isn't it? So I think you can get, steroid toxicity. So you try and taper it fairly quickly. And then what sometimes happens, and what happened in her case, was that as the steroids were tapered, then she sort of developed neurological symptoms again. So she dropped her ICE score to 1. And so she then had a steroid increase, which was just on the ward. She increased the steroids again for 3 days, and then she was tapered more slowly. She obviously had repeat imaging. She didn't have a repeat lumbar puncture. Repeat imaging was normal again. And then she gradually improved. So the other complication she had, which you sometimes do see, so she had some coagulation changes, which I'll go through. She had steroid-induced diabetes, which I think when you're giving these sort of big doses of steroids, and you should, I should obviously monitor for. And then the last thing she had was viral reactivation, which isn't very common actually, but you can sometimes see when they have steroids. So I think it's common to see low fibrinogens and prolonged PTs. It's more common in patients who have severe CRS, and it typically occurs between sort of day 6 and day 20. And the fibrinogen might drop to 0.7, 0.8. It's often after they've recovered from a CRS. And I guess you're always a little bit, it's sort of that classic, clotting thing about whether you replace the fibrinogen or not. Is it, is it all balanced, or is there an increased risk of bleeding? And I think our practice is just to replace it if it's less than 1. Empirically, I think there are some data that these patients have an increased risk of bleeding, and will obviously be often thrombocytopenic still. And I think that's the most pragmatic and most sensible approach. So she dropped to fibrinogen to about 0.9, and she had 2 adult positive cryoprecipitate, and then she maintained a fibrinogen of 1, and in fact it gradually improved from there. So you do need to monitor for clotting abnormalities. And then the other thing she had, which is not common, I think this is reported in about a few percent of people, but she was CMV IgG positive, and she sort of developed CMV reactivation, which required empirical treatment with valganciclovir. And so I think if patients are on steroids for a long time, and I definitely think about monitoring them, because it's embarrassing to miss that. So in total, she had a 28-day admission, which is towards the longer end of what we normally have. I think these patients can get a bit they can need rehabilitation if they have ICU stays and have neurological problems. And so I think physio involvement is important, and I guess a physiotherapist who knows something about CAR T is helpful if possible. And she had grade 3 CRS and grade 3 ICANS in the end. And her day 30 PET, just to finish off the story, was in remission metabolically, and then she's had subsequent negative PET CTs for disease since then. She remains in complete metabolic remission, and she's still in remission now, and I think it's approaching 2 years out. So I think this just gives you an idea. This is the first few patients we did, and I think this just gives you an idea of, I guess, the sort of what percentage of patients go to intensive care, which is about 1 in 4 here, and most patients end up with tocilizumab, and about a third of end up with steroids. And I think, I don't know, I think these numbers might have decreased a little bit since then, but and because I think there's more confidence in managing these patients. And I think CRS is common, sort of. Difficult to believe it's 100% because it wasn't 100% in the trials, but that's what we're reporting at the moment. And then, ICANS is also common. So I think you do see these things. That's what I'd say. I think my practical tips would be, so I think pretty much I always open protocol when I'm sort of managing these patients on the ward, because I think it's just helpful just to sort of remind yourself of grading, remind yourself you're not missing any of the investigations, and so on, that you're meant to do. Say, for example, if somebody has ICANS, then they need a swallow assessment, and sometimes that's quite easy to forget. I wouldn't like pour in fluid in people who are hypotensive, because they often do have a bit of capillary leak, and then they can get sort of an oxygen requirement. I think it's probably best to use steroids earlier rather than sort of hanging on and worrying about the possibility of affecting the efficacy of the CAR T, because then often they'll be sicker and you'll end up probably giving them more steroids overall. And I think ICU involvement is very helpful early, because they can deteriorate quite quickly sometimes. At the moment, it's a bit stressful if they're not known, sort of. Yeah, so that is that, I think. Hopefully within time, and I'm happy to answer any questions